So the role of SPECT CT in knee is quite challenging because in general all the knee pathologies, first line of investigation will be an X-ray followed by an MR. Only when it is complicated, if the MR specialist is not sure exactly what is happening in the knee, then the role of SPECT CT is quite complementary. In fact, it's not widely used. And currently, the role of nuclear medicine in patients with knee pain is only post-operative. Once they have a prosthesis, then the question is about whether it's infection or loosening. That's where we play a major role. But in our department, even in pre-operative knee pain, we use SPECT CT as one of the investigative modalities. Knee, as you know, has got a complex motion, and it's one of the most important weight-bearing joint, and it is prone to injury because it has got a rapid movement and it can move in all directions. And menisci separate the femoral condyles from the tibial plateau because it's got multiple bones acting in that area doing a different aspect of the same motion, and therefore it is prone to be injuries, and the injuries can be complex. It is not quite easy, and physical examination is challenging, especially if it's a chronic disease and patient can't move their limb, and often you have to guesstimate what the pathology is, and I said MR is the investigation of choice. That's how a nice knee joint should look like. The patella in the intercondylar fossa, you got a femur, you got a tibia, and knee pain, the commonest could be avulsion injuries, it could be a meniscal injury, it could be cruciate ligament injuries and miscellaneous injuries. It can be injury due to soft tissue or injury to the bone. Knee SPECT is useful because in the past most of the literature somewhere in the 80s and 90s they published on the role of SPECT in assessment of knee pain. So cross-sectional imaging, you have multiplanar reconstruction, the contrast resolution is good, you can assess soft tissue, meniscal, cruciate ligament, collateral. I used to believe this, 80s and 90s is okay, but if you go look back at all the images, what they did in the 90s and even in the 2000 era, we were just going on pattern recognition. If it is a half moon shaped or half concentric, we used to say it's a meniscal tear, and often we used to meet quite a lot of normal pathologies because everything around the knee joint we take it as a degenerative disease, but what exactly the pathology, SPECT CT can help us to delineate, differentiate and give a definitive diagnosis. Radiographic findings, arthritis is quite common here. So if you see an X-ray, you will see medial tibiofemoral and patellofemoral joint space narrowing. That's the commonest because majority of the pain, anterior knee pain in patients is due to a problem with the patella rubbing against the femur or the other bones around it. And also there will be some subchondral new bone formation. Lateral subluxation occurs, which I'll show an example. There may be osteophyte formation, joint space narrowing, and that causes quite a lot of change in the movement around the knee joint, and chronic state it becomes quite problematic for patient to use it routinely. What we do at our hospital is all patients with knee pain, whether it's pre-op or post-op, will get a two-phase bone scan and SPECT CT for all the areas, the region of interest. We evaluated quite a number of patients comparing whole body, the two-phase bone scan and SPECT CT. In fact, we are quite good in terms of localizing it, more or less okay. Localizing, characterization, arthropathy, we are quite good. Whereas in non-arthropathic conditions, we are not that good in terms of localizing and characterizing. Especially characterization, we are not that good with just a planar or a SPECT imaging. But the addition of SPECT CT, as you can see, SPECT CT is the one with the red. We are quite good in localization, characterization, whether it's arthropathy or non-arthropathy. SPECT CT often gives a definitive diagnosis in most of the patients. This is a paper from Rizwan's group. They evaluated about 105 patients using SPECT CT clinical assessment of painful knee prostheses, and in fact they found SPECT CT was useful in about 85% of the patients to say whether what the pathology is, because often we think after knee replacement only problem will be infection or loosening, but there are other pathologies like fractures, the patient can have maltracking, or the patients can have biomechanical stress, or even the physiological uptake. In fact, about 40 to 50% of the patients after knee replacement will have patellofemoral arthritis, which I will come to that later, because that will be the commonest pain in patients we often have to look for, because often we look only at the prostheses and trying to find whether it's infection or loosening, but the main cause there would be just patellofemoral arthritis in patients with knee replacement. Another example, this is from Switzerland, one of my orthopedic friends. So they looked at role of SPECT CT in assessment of tunnel orientation. In fact, they are quite good. This is only center. They have their own device and the scorings, and they do it quite well, because in the whole project there is an orthopedic surgeon who is involved, and the scans are reported along with the orthopedic surgeon. So he tells the reporting people whether the uptake is normal, whether it's physiological, or this is the expected uptake, what he will see in a particular surgery. So if you know that, then it's easy to differentiate physiological or the benign uptake from loosening or infection. So unless we get information about the type of prostheses or type of surgery, it is very difficult to interpret accurately. So all we need is a good information from the orthopedic surgeon, and we have to understand the dynamics of hip or knee replacement. If you don't understand that, and we are just going on a principle of mathematics that increased vascularity, increased uptake, likely infection, or normal blood pool, abnormal uptake, more likely loosening. This is again looking at evaluation of mechanical loosening using SPECT CT, and in fact SPECT CT significantly improved the diagnostic. In fact, the sensitivity was around 86%, specificity was 86, positive predictive value was relatively higher when compared to SPECT and the planar imaging. So if you do a SPECT CT, this is how a normal scan should look like, and normal patients don't get a SPECT CT. So of course they will come with pain, but if you do a SPECT CT, you'll have a normal scan. In this case, as you can see, a nice femur and the patella sitting in the fossa nicely. I'll show quite a lot of examples where the patella maltracks. So this looks physiological uptake around the knee joint, no abnormal uptake, so it's a normal knee joint. Osteochondral defect is very common. Often knee is the commonest site people get injured, and in this case the patient got multiple surgeries for anterior cruciate ligament surgery, and post-surgical he's got all these micro fractures. As you can see, there is a small defect here around area of sclerosis, and that is definitely an osteochondral defect. So depending on the size, location and the extent, osteochondral defects can be diagnosed, and the treatment is conservative to a very majority of the patients, but if it's persisting of its fractures, then arthroscopic debridement is the treatment of choice in patients with osteochondral defect. It's very common, very common. If there's a small focal uptake, even in a normal knee joint, the clinical suspicion should be whether the patient has got an osteochondral defect. If it's very focal, very small in a knee joint, even you have to suspect an osteochondral defect. This is again another example of an osteochondral defect. Patient with pain, focal uptake like this. Nowadays with SPECT CT, because we have seen quite a lot, without the SPECT CT also you can raise a possibility that could be an osteochondral defect. If you look at the MR, you can see high signal followed by reduction in signal in this area. As a MR is used for majority of the diagnosis, and it's got a specificity around 95 to 98%. But as soon as the patient undergoes surgery, then there is a role for SPECT CT, because most of them will have SPECT CT rather than an MRI in this group of patients. Another example of an osteochondral defect, and I keep showing this because it's quite common. We often detect patients with metastatic renal cancer, pain in the right hip and the knee pain, and if you can look carefully around this area, there is a sclerosis with a central photon deficient area, which is a classical finding of osteochondral defect. Patella is the most complicated part of the knee joint because it is quite flexible, it moves in all directions. In this case, there is a focal uptake here, and if you could see this patella and this one, even though it is slightly even maltracking, but this one is just out of focus. So there is an increased uptake here, which is not in the fossa, it is going outside. Patient got persistent pain, so it is subluxated. So patellar instability is a common and a disabling condition. All scans look similar. For example, see this case, majority of the bone scans we review, most of them will have uptake like this. In general, whether it's an oncology or non-oncology patients, we often generally label that as degenerative disease. But if they have a specific pain around the knee joint, we have to be a little bit careful. Again in this case, you can see the femur, but it's not in the fossa. The patella is maltracting, it's going outside. If you see the previous scan, if you see the normal, the patella has to be within the socket. Whatever it is, it has to lie down there. But if it's moving in this direction and this direction, and it will impinge on this bone. As you can see, there is lots of joint space there, and it will keep hitting this bone when the patient walks or turns, and that will lead to persistent pain in these patients. That's how patella should be. Ideally, within the fossa, you can see it's nicely labeled, but in this case, the patella is moving towards the lateral aspect, so it's called lateral maltracking. So the best diagnostic test in this is dynamic MR is the diagnostic of choice. But this patient came for a bone scan with knee pain, whole body bone scan looks unremarkable. This is the finding we see in 90% of our bone scans. Majority of them we will not comment. We took an extra SPECT CT of this area because patient complained of a knee pain. The indication was specifically for that, and this is one of our first cases because we know, and we just called it as degenerative disease. But because we jointly report with our musculoskeletal radiologist, and he said this is a classical finding because it is not in the groove, it is maltracking because it's pulling towards the other side. Especially when you extend your leg, it has to go into the groove. What will happen is instead of going into the groove, it will maltract to the lateral aspect or sometimes into the medial aspect. So it accounts for nearly 20 to 30% of reported knee disorders. Patella does not run properly in the trochlear groove. If it is not placed correctly in the intertrochlear groove, it will move in opposite directions, causing significant pain in motion. Another example is quite common because we see on the bone scan when we say degenerative disease, but we do a SPECT CT, you can see there is loss of joint space. The patella is also moved, and also there is cystic changes, and there is loss of the cortex. It's all classical pattern of severe degenerative disease. And this is one of the commonest indications for knee replacement. That's also the thing. In fact, in the past when they used to do knee replacements, half of the time they got it wrong because the patient usually had hip pain, and because they got hip pain, they used to put quite a lot of pressure on the knee joints. So the doctor thought that the problem is the joint, knee joint, not the hip joint. So half of them used to get an unwanted knee replacement because they couldn't find the pain generator. This is again bilateral patellofemoral arthritis. Because it is so common, I have shown more than 3 examples of similar pattern, is because this also looks exactly the same. If the patient complains of knee pain, patient should have a SPECT CT, and I think majority of them will have chronic pain, will have patellar maltracking. It's quite common finding. To meniscal injury, again the role of nuclear medicine here is very minimal. So if there is any soft tissue injury, MR will play a significant role here. This is the medial meniscus, that's the lateral meniscus, and whenever you see a half moon shaped appearance on a SPECT scan, people in the past used to say it is a meniscal tear. That was in the 80s and 90s, but now after MR, I think so very less frequently we use bone scans to assess meniscal tears or any soft tissue knee pathologies. This is a classical pattern. Patient's got a twisted knee injury. He's already been operated for a meniscal injury, and you can see there is a half moon appearance, the concentric appearance, and that's where the patient has had a trauma. Coming to the literature, what does it say is meniscal injuries produce disability in large population. It's a commonest site. Often they have knee as a major problem. Medial meniscus injury is more common when compared to the lateral, and in fact successful meniscal repair significantly enlarges. But once, even after the repair, the patient often has very significant pain in this area, so you need a very adequate physiotherapy and change in walking style, and all these factors does help to get it into a regular shape. That's another patient who had a lateral meniscectomy for consideration of meniscal transplant. So the patient, the physician or the orthopedic surgeon wants to know whether there is increased metabolic activity in that area. All knee looks the same. If you could just keep watching all the scans I show on the whole body, it looks unremarkable. Everything looks quite straightforward. Whereas as soon as you do the SPECT, it gives additional information, and you know exactly that's where the increased uptake is. That's the commonest pattern. If you see uptake like this, like the kissing pattern, that is very common for degenerative disease. That's one of the indications for patients to have surgery or meniscal repair. Avascular necrosis, again, in this case, the patient has got a dual transplant. You can see 2 transplant kidneys there, and the patient had knee pain. Again, it's quite a non-specific finding on a bone scan. There are 2 focal uptake. What is that due to? But on the combination, you can see there is sclerosis, cystic changes, bilateral, and in fact, the patient had more pain in one of the legs, but the diagnosis was bilateral avascular necrosis, and the patient had bilateral knee replacement for the avascular necrosis. So in fact, it is avascular necrosis of knee joint is the second most common site for osteonecrosis, and imaging, as I said before, MR plays a major role. Just because in our department the imaging algorithm is slightly different when compared to others, because the radiologist who works with us is also trained in nuclear medicine, and therefore he gets all the referrals for MRIs. So he decides which patient will go for a nuclear medicine scan first, or which patient will have an MR followed by a SPECT CT. So he is the one who decides. Therefore, we get the best of the cases, or we use the best of the modalities to get a better answer. Knee injuries, this is very common. As you can see, this is whole body bone scan, subtle uptake, increased vascularity there, and there is uptake there. Again, without the proper history, we would have said it's non-specific, or it could be any post-traumatic. But in this case, if you do the SPECT CT, there is a clear focal uptake at the superior aspect of the patella, and there is classical finding of a quadriceps tendinosis. If you see an uptake like this, you can just close your eyes and say that's quadriceps tendinosis injury. You can't get anything else around that. It is basically an overuse injury. Pain tends to develop gradually over a period of time, and especially in weightlifters and older athletes, you are prone to get quadriceps femoris injury. So if this is a knee pain, focal uptake, any knee pain, focal uptake, if you're not sure, it's best to do SPECT CT. Miscellaneous conditions, this is quite interesting because there is increased uptake. Patients got less knee pain. On the bone scan, you can say it could be a patellar fracture, or it could be just degenerative disease. But doing the CT bit, again you see a patella and there's a break here. So that's not a fracture, that is a bipartite patella, which is a normal variant. If you don't know that is a normal variant, I can easily call that as a fracture. Easily you can call it, even if I have not known the terminology or about bipartite patella, I would have thought that is a break in the patella, that's classical for a fracture. But that's a normal variant, and in fact it is an incidental finding. Often it's asymptomatic. When it becomes symptomatic, the non-surgical option is just to give them painkillers, and if it's persistent pain, sometimes it may fracture, then the patient will have an excision of the fragment. So whenever you see a break in the patella, rule out a bipartite patella. Don't think it could be a fracture. This is another patient with sickle cell disease, and the question there was whether the patient has got an infection or any other related, but we did the whole body bone scan. These are all marrow changes, which is quite common in patients with sickle cell disease. And on the CT component, you can see there is diffuse sclerosis and there is trabecular coarsening. All these are trabecular coarsening. That is classical for patients with sickle cell disease. This is a nice example. A patient, the clinical question was whether this patient had osteomyelitis. I mean, this is straightforward osteomyelitis. This is increased vascularity, increased uptake. I would have said, there's no need for SPECT CT here, but now routinely we do SPECT CT in infection imaging, and this was branded as Broody abscess because there is extensive marrow approaches. If you can see, there is a lesion, and with the cortical surface extending into the soft tissue. That was a classical example of a Broody abscess. Okay. And another incidental finding, focal uptake is again non-specific, whether it's on the bone scan or on the SPECT scan. And in this case, there is calcified sclerosis in this area, and the diagnosis was an enchondroma was diagnosed in this patient. And whenever you see such findings, you have to look for whether there is any narrow zone of transition, whether it's sharply demarcated, or whether it's solitary or multiple, or whether it is expanding, or it is overlying the cortex, all these factors have to be taken into consideration. But again, whenever you are in doubt, the next investigation of choice will be to do an MRI or refer this to a bone tumor clinic. So they will just exclude whether it's benign or malignant. Post knee replacement, I'll just cover it because it's quite a challenging aspect. Whatever type of surgery you do, however good the surgeon is, nearly about 20 to 30% of the patients will not be satisfied, irrespective of whatever you do to them. That's a standard orthopedic opinion. You need to have a good clinical history, a thorough clinical evaluation, and that's what they will do routinely by the orthopods. They will do this to assess the weight bearing and all sorts of x-rays to see whether the prosthesis is in place. And this is a standard algorithm they use at in Switzerland. If it's an infection is the clinical question, they do a lab work, joint aspiration, microbiology and arthroscopy. In fact, the European Infection Society and Orthopedic Society are also coming up with a document saying that there is no role for any imaging in patients with knee pain post knee replacement. Whether you use radiological imaging or nuclear medicine imaging, nearly half the time you don't get the answer right. So if they are thinking clinically in terms of an infection, they say the best investigating procedure will be just to put a needle and find the diagnosis whether it's infection or not. But that's why we are having a problem in sorting out the European Association of Nuclear Medicine bone guidelines, whether to include two-phase bone scan or white scan in the algorithm or just to leave it, or to make up, we have to justify whether what is the role of knee SPECT CT, because writing a EANM guideline is quite challenging because it's written by about 8 people, and then it goes to the board, which is checked by nearly another 20 people, and once they're happy with that, then it is sent to 33 countries to read it and comment on that. So when the guideline comes out, it nearly takes 2 years or 1 year for everybody to go through and comment, and then we finally do it. So it's quite challenging whether to include problems associated with the prostheses. Especially prostheses is quite challenging because whatever we do, unless we have a feedback from the surgeon, we are just doing it quite blindly. If you have a feedback from the surgeon, what we are calling is right or wrong, then we can definitely add to their diagnostic implications. So with instability, they usually have a stress X-ray, ultrasound, impingement. Again, as I said, they'll go for an ultrasound. Fluoroscopy, if they're not convinced, very rarely they go for an arthroscopy. If it's malpositioning, they don't need additional stress. They just do a SPECT CT and Switzerland. Imaging post TKR, the standard investigation is X-ray, okay, and they detect if it's a gross. In fact, if it's a real loosening, it's a gross loosening, a plain X-ray can just tell you whether the prosthesis is loosened. But if it's a very subtle loosening, X-ray may not pick up. CT is useful in identification malposition or may reveal extent and size of periprosthetic lucencies or any other fractures around the prosthesis. Heterotropic ossification and all those things can be assessed on the CT. So the role of nuclear medicine there again will be, if there is increased uptake and increased vascularity, you have to check whether the uptake is within the prosthesis on the bone or in heterotropic ossification, because heterotropic ossification is very common post-operative because it's a bone formation around it. So we have to be very clear to tell them that the uptake is not in the prosthesis, it is the heterotropic ossification, which is a degenerative pathology. Bone scans or SPECT will show osseous metabolism and joint homeostasis. Clinical value is limited because of poor accuracy in localizing the tracer uptake, because what we did in the 80s, 90s, even in 2000, based on increased uptake and vascularity, is not that straightforward to an orthopedic surgeon. In fact, if you strictly speak to them, half of them even don't see the report what we report, because they do it just because it is part of the diagnostic algorithm. But they think they can sort it out, go into the surgery, open up, and then they'll find whether it's loosened or not. By shaking it, they'll know whether it's loosened or not. So this is the algorithm they use. Even I'm trying to understand this. This is how they use it in Hirschman's clinic, based on where the focal uptake is, and they make an accurate diagnosis, giving scores to each part of the prosthesis around the knee, whether it's the tibial component or the femoral component or the patella. But as I said before, after total knee replacement, nearly 20 to 30% do not achieve satisfactory outcome. Whatever you do, they are not happy. So what are complications? Early complications include infection or instability. There can be malposition of the components, patellofemoral maltracking is very common after surgery, or there can be soft tissue impingement. Because in nuclear medicine, all we know is complications in terms of infection or loosening. Beyond that, we don't even think about it, and although there are few literature. Late complications of a knee replacement is loosening, infection from distant infection, extensor mechanism, or avascular necrosis, patellofemoral arthritis. Patellofemoral arthritis is the commonest. In fact, nearly 30 to 40% of patients after surgery, the commonest thing you have to exclude when they complain of anterior knee pain is patellofemoral arthritis. And it is important to assess patellofemoral arthritis because when they do knee replacement, some people do what is called a resurfacing. They shave off a bit of patella. Resurfacing again is not done routinely. It is done routinely in the US. It is not done in the Asia. It is done off and on in the Europe. In the Europe, they do resurfacing at the time of surgery if the patient complains of anterior knee pain, if they have a damaged articular cartilage, they have inflammatory arthritis or patellar subluxation maltracking, then patient will have resurfacing. Otherwise, they will not have resurfacing. Whereas in the US, all patients routinely have resurfacing. The reason they do resurfacing is if they don't do it, that 20 to 30% of the patients will come back again with anterior knee pain. But the problem is, once you do resurfacing, the complications of resurfacing are patient can have patellar fracture because you have shaved off a little bit, it becomes quite thin, and you can have osteonecrosis, you can have extensor mechanism, you can have aseptic loosening, and also they stuff the patellofemoral joint because you have shaved it, you have to give some support in between the patella and also the knee joint, and therefore they stuff with polythene wear that itself can cause problems later on. And there is also called as a Patellar clunk syndrome. So because there is a loose between the patella and the prosthesis, that could give problems to the patient. So whether you do or not, it depends again on individual departments. But most of the problems after total knee replacement will be patellofemoral arthritis. That's what we need to think. Whenever you look at a bone scan SPECT CT knee joint for infection and loosening, most of the time that will be normal, but look for the patellofemoral junction. If there is increased uptake, the cause of the pain is patellofemoral arthritis. This is a patient having a SPECT CT of mechanical loosening. As you can see, there is increased uptake in this area. This is from the Hirschman group, and they have labeled it clearly as loosening of the patellar component of the total knee arthroplasty. Another example, loosening of the tibial component. There are two focal areas of increased uptake and also at the tip of the tibial component, and the diagnosis here will be loosening. So if you have an orthopedic surgeon along with you, that makes quite a lot of sense. At least have a follow-up, at least have a chat with him saying that this is how the scan shows, what do you think about it, and it helps quite a lot. And if you could see the patella, there's hardly any uptake there, so that looks quite a lot normal. Another example here, patient has had a total knee replacement. There is focal areas of increased uptake, but on the CT component, there is a break here that is due to fracture. It's not the loosening is secondary to fracture on the CT component. And again, this is not an ideal image because we gave only 100 MA in this, I think so. But if you're doing prosthesis imaging, you have to at least give about 140 or 150 MA so that we can avoid all these artifacts, because it will provide quite a lot of artifacts and it will show quite a lot of lucency. The lucency should not be mistaken for loosening. This is another example of a patient. The clinical question was whether it was an infection. There is a focal slight increase in blood pool, and there is increased trace at uptake, and the diagnosis was degenerative disease in that. And this is how the bone scan will look like in patients with patellofemoral arthritis. Classical, there is nothing there, and if you could see, there is some increased uptake in the patella, very focal. But if you do the SPECT CT, you can see that is the patella, and you can see there is significant increased uptake in this area. So the problem in this patient is due to patellofemoral arthritis. All he needs is resurfacing rather than replacement. Another example, focal area of increased uptake, patellofemoral problems. The prosthesis looks overall fine, the uptake is within the patellofemoral junction, whereas the entire prosthesis looks fine, patellofemoral arthritis in the patients with total femoral arthritis. So knee SPECT CT, it helps in detection, helps in accurate localization, bone and joint surface characterizes anatomical abnormalities, and what it does overall to the outcome is it increases sensitivity, improves your specificity, accuracy, and also the diagnostic confidence. Pre-surgical knee SPECT CT is overall it's okay, but for the post-operative knee SPECT CT, it's still evolving. If you want to do it right, you have to spend quite a lot of time with your orthopedic surgeon to find out exactly how they do the surgery, because it's not basically because of loosening. Even if there is a slight tilt, or based on type of prosthesis they put, because if they put a prosthesis based on what type it is, the patient walks in various styles. So if he knows that this is a particular prosthesis, the orthopedician knows that the particular patient will put stress on the lateral aspect or a medial aspect. So if you see an uptake in the medial aspect, and if he's had a particular surgery, then the orthopedician knows that's the normal uptake. You may think it is abnormal, but for an orthopedic surgeon, he says because the type of surgery is done, that is where the patient is going to put stress, and that is a normal biomechanical stress. So therefore, unless you have a chat with your orthopedic surgeon, bone SPECT CT, especially in post-arthroplasty, will be challenging. So role of knee SPECT CT, addition to SPECT CT, bone scintigraphy, incremental value, diagnostic confidence, problem solving when MR is inconclusive, and it plays a complementary role, as I said, because the first line of investigation will always be an MRI. Nuclear medicine in knee pain will be complementary to MRI.